Good morning, my dear colleagues. Today I'm presenting a subject which is not a very usual subject to be presented by a psychiatrist. I will be focusing more on the psychiatry part when we start prescribing as physicians from all specialities pain medications, especially narcotic pain medications.
Recording in progress.
So I'll start by introducing many types of pain. First, we define pain as unpleasant sensory and emotional experience associated with actual or potential tissue damage, or describes in terms of such damage. Acute pain and chronic pain. Acute pain can be brief, lasting from minutes to hours, and can persist and last for weeks or even months until the disease or injury heals. The condition has a predictable beginning, middle, and end. While chronic pain is pain that has persisted beyond the normal or expected time regarding the original condition and injury. There is also a definition which is chronic pain syndrome. It's at the end of spectrum of chronic pain. The work group defines this as a constellation of behaviors related to persistent pain that represents significant life role disruptions. There is the visceral pain, as you all know, it's related to body organs, radicular pain, which is related to nerve root, somatic pain related to body wall, and allodynia, which is a type of neuropathic pain, sensitivity to light, touch, or wrapping. Analgesic tolerance is another definition. It's the need to increase the dose of opioid or painkillers to achieve the same level of analgesia. Biopsychosocial model addressing the whole person in all his or her complexity, including physical, biological factors, psychological state and beliefs, social situations, as well as the family and work environment. Neuropathic pain, as we know, is a pathological change in the peripheral nervous system. Opioid-induced hyperalgesia is opioid may lead to paradoxical increase in pain despite receiving increasing doses of opioid. Substance abuse. Substance abuse is the use of any substance for non-therapeutic purposes or use of medication for purposes other than those for which it was prescribed, to get high or to relax. Okay? Tolerance is a state of adaptation in which exposure to a drug induces changes that result in reduction of one or more of drug effects over time. So when the patient develops tolerance, they usually ask for increasing the dose of painkillers. Addiction is a primary chronic neurobiological disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. It is characterized by behaviors that include impaired control over drug use, compulsive use, continuous use despite the harm, and plus craving. And usually these kind of emotions will lead to catastrophic social, financial consequences. Pseudo-addiction is the pattern of drug-seeking behavior of pain in patients who are receiving inadequate pain management. That means they are in real pain, but the pain medications is not enough to cover their pain. So they might look like drug-seeking or addicts, but they're not. So we have to differentiate. Psychogenic pain, it's pain that happens due to factors other than physical illness or injury, also known as psychosomatic disorder. This is actually related to our specialty. I gave you some examples that I'm sure all of us see, especially the general physicians. Hypochondriasis, which is the belief that I have a serious illness that wasn't detected, so they go from a doctor to doctor and do all this unnecessary imaging or procedures, and they usually never get convinced. Even if they are convinced for a short period of time, they will still doubt the doctor qualification, the machines itself, the lab. So they will go on until they reach to the right place, which is a psychiatrist clinic. Somatization disorder, also very common in ladies in middle age. They have all multiple kind of unrelated somatic symptoms like vague abdominal pain, paresthesia, dysuria, and when you go and screen them, you don't really find any origin to their pain. And usually they would have depression. If you go through and dig through, you will see some social issues, and we will have to treat the underlying cause before treating their pain. And of course, underlying personality disorder. Pain is a very common finding in people with borderline personality disorder. They're always in pain. They're always not satisfied. They're always doubting. We have really many examples here of people with borderline personality disorders, and they are hard to treat. Here is a nice diagram that I got from our colleagues. Actually, this is made by our colleagues in Ministry of Health to guide the physicians for pain management. It's acute versus chronic. In acute, if it's brief or persistent, what shall you do? Determine the characteristics, and then you go and see the related symptoms. This example is actually made related to sickle cell disease in sickle cell center. I can pass it by to you if you need it later. This is the most important slide that I want to highlight for you. Is it clear here? Here we go here and then Kavita. This one? Okay, is it more clear now? So actually, we came up with this presentation because of some incidents in the emergency of patients with drug-seeking behavior who were not satisfied when the doctor was not convinced to give them the medication that they asked for. So we are referring, actually, there's the idea, and we will plan to have a committee to come up with a policy that helps all the physicians, especially in ED, with dealing with patients with drug-seeking behavior if we suspect that. Okay, so again, this example is taken from Ministry of Health. We can take whatever suits us and put our own policy. For example, here, if a patient has more than 5 continuous visits or more than 10 alternative visits in the last month or last 30 days to ED and need breakthrough pain treatment, or patients who are in observation area, physicians must follow the guidelines. They must, what happens here is patients come and ask you, don't do labs. This is a real situation that we had here. Actually, they don't want to do their CBC. They just came for morphine, for example, like a sickle cell disease patient. It's actually the physician right to refuse if the patient did not agree to have the necessary investigations, lab investigations, because we had incidents, not in this hospital, but we know them by name. What happens in the ED is, unfortunately, the narcotics is not registered, unlike the prescribed medication. It's not registered in the CDBS system, okay, the controlled drug prescription system. So the patient, what patients usually do who have addiction issues, they will go from emergency to emergency, from hospital to hospital, and it's not registered. So our physicians here, they don't know if this patient went to, AMH, Al Hilal, whatever, and this could lead to opioid overdose and death. And we had incidents like that. So my first advice is to register even the medications which is given in the emergency, not necessarily the prescribed ones. So I encourage you all, our colleagues, to get a subscription in this system, because this will save us a lot of hassle and medical legal issues. A point here is, yes, another example here, we see point number 7. I'll skip some points here. Patients with drug-seeking behavior will usually come to you and tell you, I'm allergic to Finargan, Tramadol, Bethadine, and I want morphine. So they put you in a corner. They said they're allergic. And usually what the physician should do is ask them to have an allergic test. If they refuse, we have to document this, and at least we give them a test dose of Phenergan because it's the safest of all these. Okay. If the patient again came to you and he looks under the influence of medication, lethargic, slurred speech, constricted pupil, and he's insisting to get, then you will have to order urine toxicology. If they refuse, then you can just stick to your position and refuse to give them their pain medication. And document, of course. First and most important is to document the symptoms that you see, and this is to protect you and the hospital from later on complaints that were not necessarily. Yeah, so this is about it. These points we need to do. I had a discussion with Dr. Qasim earlier that we will need to have our own policy, including emergency doctor, anesthesia doctor, because their scope of specialty covers the pain management, plus a psychiatrist. Thank you so much for attending. Any question?